Assalamu alaikum everyone, it's Dr. Sadaf here. On behalf of STSP Lahore chapter, I welcome you all in our today's online session.
खाना भी खाना नहीं तो फिर मैंने नान को बुलाया नहीं
Um,
नान को बुला लो
you all are requested to kindly mute your microphone while you are online so that we can... Dr. Sadia, can you please switch off your microphone? Thank you very much everyone for joining in. We are glad to have Dr. Moazzam Ali today. He's a consultant anesthesiologist and pain specialist. Currently, he's leading the Department of Anesthesia and Pain Medicine at Combined Military Hospital, Lahore, Kent. So today he'll be talking about phantom limb pain, all about the etiology, pathophysiology, and the management. Thank you, Dr. Moazzam, for joining in. You can take over the session now. Over to you, Dr. Moazzam.
Thank you very much, madam. Can you hear me? Hello.
Yes, sir. Yes, sir. We can hear you and we can see your screen as well.
Okay. Thank you very much again for inviting me. So let's start. The topic that was given to me was phantom limb pain. So what is phantom pain? It is basically any kind of sensation, pain or dysesthesia which is present in the body parts that are no longer there. Okay. This is a very generalized definition, and we'll see later on in detail what are the types of phantom pains. So the history dates back to very long time, at the time of the ancient Egyptians, and but it was first described in the 16th century by a French surgeon who described this phenomenon of phantom pain. And this term phantom limb pain, it was first used in the 19th century by an American physician. Phantom pain has a lot of prevalence. Some studies say that it is up to 90%, but in literature commonly they say it is about 64%. A recent study, a South African study, it shows the prevalence rate of about 71%. And because this is mainly phantom pain is present because of the limb loss. So, and it due to these international conflicts and everything, the limb loss continues to increase, and it is estimated that by 2050, about 3.6 million people would be suffering from this limb loss. Along with the limb loss, phantom pain can also occur due to mastectomy, and also in some patients who undergo enucleation of the eye, they also can suffer from phantom pain. So this is a generalized classification. Basically, when a limb is amputated, so a patient experiences different kind of things. It could be a phantom sensation only. It could be a residual limb pain. It could be phantom pain, or it could be telescoping. So phantom pain, it is the perception of pain originating from a limb that is no longer present, and it is commonly described as burning, aching, throbbing, or cramping type of painful sensations. And opposite to that is the phantom sensation, in which the sensations are non-painful, but these are perceived in the missing limb, and these include tingling, itching, coolness, warmth, or even the patient may complain that he is able to move his cut off limb. The third entity is a stump pain, the remaining side that is present. The pain could be at the stump, and it originates at the surgical site. And the stump pain is usually caused by an infection or the nerve injury that is cut during that amputation process, or it could be due to the poor wound healing process. Another phenomenon that we see is telescoping. In this phenomenon, there is a progressive sensation in which the patient feels that the distal limb is being moved slowly, proximally towards the stump. So this shows that basically his experience or these painful things, it is improving, this telescoping phenomenon. So types of stump pain, these can be broadly classified into incisional pain, neuropathic pain, or musculoskeletal pain. Incisional pain is due to the surgical incision itself, and it subsides within weeks to months. Then is a neuropathic pain because a lot of nerves are present along with muscles and everything. So because of the damage of the nerve, the pain that arises is known as a neuropathic pain. It is usually chronic and difficult to treat. Then comes the musculoskeletal pain. It is due to all the muscles and bone, soft tissue that is present. There is one of the cause of the stump pain. So, phantom limb pain commonly occurs when there is a limb loss, and the common causes of limb loss all over the world is peripheral artery disease. We have seen that due to this disease, the patient needs to undergo amputation. Then comes diabetes, leading to gangrene and everything. The another cause is trauma, which is also one of the common causes. Could be due to these vehicle accidents or these international wars. It leads to this loss of limb. And then other causes are like cancer, congenitally, there could be their limb could be absent, and then there are some infections which affect the limbs, and in that case the limb needs to be cut off. So uh, not every patient develops this phantom limb pain. There are certain risk factors which are present and which leads to the development of phantom pain. Commonly is the persistent preoperative pain, if it is there. Then is the residual limb pain or that stump pain, that also known as a stump pain, if there that is present. Then is the phantom sensations, where these also leads to are converted to phantom pain later on. Then it is said that lower limb amputations, these are more likely to develop into phantom pain than upper limb. Then there are some psychological factors like anxiety, depression, emotional distress. They also play a major role. And another risk factor is this proximal site of amputation. For example, if there is a below knee or above knee amputation, so most probably the develop phantom will most probably develop in above knee amputation, because that is more proximal to the body. So the mechanism of phantom pain. Phantom pain, this arises, they are basically divided into two or three basics. It can be central or peripheral. Central is that towards the brain, the things which occurs in the cortex, and then peripheral is divided into the spinal cord and this peripheral mechanism at where there is it is the limb is cut off. Okay? We will see these all in detail. So the peripheral changes which occur. This peripheral input, it plays a major part in the perception of phantom pain. When these peripheral nerves are cut or injured, the regenerative sprouting of the injured axons, these occurs. So the enlarged and these disorganized endings of C fibers and A fibers, what they do is there is a increased rate of spontaneous activity, and this spontaneous activity, which mostly it occurs at the neuromas, the cut end of the nerve, and in the nerve endings, and also in the spinal ganglion. So, as a consequence, or there is upregulation of the sodium channels because of all these mechanisms. There is also ectopic discharge in the dorsal root ganglion, the DRG, which is also implicated as a potential mechanism. Or this ectopic discharge, it can also be induced by emotional distress, leading to increased circulating levels of epinephrine. Some other factors like temperature, oxygenation, these also play a role in development of this phantom pain. Then comes the central changes, in which is the spinal cord changes. So in the spinal cord, basically what occurs is you people already know that there is central sensitization. Sensitization takes place, and what is sensitization? It is a process where these neural activity increases and the neuronal receptive field expands, and the nerves then become hypersensitive. And because basically this is due to the NMDA activity in the dorsal horn of the spinal cord, which makes it more susceptible to the activation of substance P, tachykinins, and neurokinins, and which is then followed by the upregulation of receptors in that area. So this restructuring of the neural components of the spinal cord, it caused the descending inhibitory fibers to lose their target site, and the combination of these increased activity and these nociceptive signals, and this decrease in inhibitory activity from these centers in the supraspinal centers, and they are thought to be the major contributors to development of this phantom limb pain. And uh, these are the functional changes that occur, and the anatomical changes that we see are the afferent C fibers of lamina 2 in the spinal cord. They may degenerate, so that the number of synapses within the second order neuron, these decrease in number, and these A beta fibers, they are present in the deep layers. They may connect with these exposed nociceptor second order neurons within the lamina, and which may induce sprouting of the A fiber terminals in these areas where they are normally not represented. So the incoming A fiber input might then be interpreted as noxious, and could be the anatomical substrate of allodynia. In this way, these normal stimuli through A beta neurons, they may lead to these pain sensations. I hope you understood this mechanism at the spinal cord level. Then comes the changes in the brain. So we have seen that over the past years there has been significant research into the cortical reorganization, and this cortical reorganization, it has been cited as a common factor in development of phantom limb pain. So during this process, the areas of the cortex that represent the amputated areas, these are taken over by the neighboring regions in both the primary, in somatosensory and the motor cortex. And this cortical reorganization, this explains why the nociceptive stimulation of the nerves in the residual limb and the surrounding area can cause pain and sensation in the missing limb. And there is also correlation between the extent of this cortical reorganization and the amount of pain that the patient feels. Okay. Then comes another factor which is also very important. It is the psychogenic factors, and we all know that this chronic pain, one of the strong element is this psychological component is very important, and this phantom pain, it is type of a chronic pain. It often leads to chronic pain and can develop into chronic pain, and if there is a higher chance of success only when these concerns are addressed, patients' pain behaviors and the pain processing behavior is addressed, and other issues like depression, anxiety, increased stress, which all these are the triggers for the phantom limb pain, and these should be treated alongside the other medicines that we give during the management of phantom pain. So this was all about the pathophysiology and the mechanism. Then comes we have to describe how what is this type of pain. So phantom pain, this is basically a neuropathic pain, and it varies in character, duration, frequency, and intensity. And commonly it is sharp and dull. Sometimes the patients says that it is burning or cramping like pain, or shooting like, uh, or just electrical shock like sensation. So different types of complaints, but uh, uh, normally we can assess that it is a phantom pain, and mostly it is intermittent pain. It is not constant, but some patients may complain that it is of constant nature. and it not only occurs in these limbs but can also occur in the tooth, breasts, or testes if these are removed. And the normal time is within the first 6 months of amputation. So the presenting time is within the 6 months. And uh, how long it takes, sometimes even it takes years to subside. So it is basically a chronic type of pain. And a few studies also say that it may also be precipitated if a patient who has an amputated limb, if he is given spinal or epidural anesthesia. So this in life it may also get again precipitated by this type of anesthesia. So how do you evaluate? First, you need to identify the etiology. Then etiology is just how you can see that limb is amputated, and then you have to classify whether it is a sensation or it is a phantom pain, or it is that residual limb pain. The comes the inspection and the palpation part, because you need to address those as well. You need to see the break skin breakdown, pressure sores, infection, uh, ischemic changes, color changes, if there's any mass. Then there could be on palpation, there could be soft tissue tenderness. Tendal sign is very important to check the presence of neuroma. Okay, so you would have seen that we normally check the tendal sign at the stump to check if there are any painful neuromas are present that are causing the pain or not. Some investigations, we can do these imaging, x-rays, cts to rule out other causes. To see the infection, we can check the inflammatory markers, but normally these are not routinely indicated, and the diagnosis can easily be made on the basis of clinical examination. So once you think that it is a type of phantom pain, then you have to differentiate between these two. The stump pain is localized to the residual limb, and whereas the phantom pain, it is perceived in the missing limb. The quality of pain could be different. The stump pain is mostly sharp burning. The phantom pain includes wider sensations like burning or cramping or throbbing type of pain. And then the onset of time, stump pain is usually immediately after surgery it develops, and the phantom pain, it may develop immediately after surgery, but commonly you've seen that it develops a few days or weeks later after the surgery. Okay. Then comes the management, uh, but before the management we have to do, if we can do anything to prevent this development of phantom pain. So the studies indicate that using of preoperative epidural anesthesia or perioperative IV patient control anesthesia, it could be this perineural infusion. We can place a catheter along the nerves. These can all uh, help in prevention or then later on development of this phantom pain. But once it develops, then what management options we have? We will start with the non-pharmacological options, because start with the things that we can treat. We need to involve all the specialties, the rehab specialists, the surgeons. Then the things we need to look at are the contractures, because once the contractures develop, they lead to musculoskeletal pain along with this neuropathic pain in the neuromas. Edema should be limited. Post-op analgesia, adequate post-op analgesia should be given to the patient. Then there are some desensitization procedures that use of massage, bandaging, etc. Prosthetic training, which is done by the rehab specialist. Medicines can be given in the pre-op time, and which continued later on in the post-op to control this development of pain. And lastly comes the surgery. Uh, the non-pharmacological options, if we explain a little more, that we see mostly what we do is first we refer the patient to rehab specialist and the physiotherapist, and we have seen that normally they do the TENS therapy. They normally employ this TENS therapy. They use the mirror therapy. Then, with the help of psychologist, biofeedback, this cognitive behavioral therapy is important. Use of support groups. Then ultrasound therapy, acupuncture is very effective. And then these are some newer treatments of virtual or augmented reality. These are basically the non-pharmacological options that can be used. Then comes the medicines that are used for the treatment of this pain. We start with this simple paracetamol or NSAIDs and then keep on increasing. But it is usually advised that multimodal therapy should be used. A combination of this acetaminophen, low potency opioids, antidepressants. These are very important. We can use any one of them, or even we can use the combination of antidepressants and anticonvulsants. Ketamine infusion, we have seen that it is also very effective. It can be given daily or on weekly basis. And then some studies indicate the use of beta blocker, calcium channel blocker, uh, this topical capsaicin, this mixture that is available. It can be used for the treatment of this neuropathic pain. Neuromas or these contractures, these can be injected with this botulinum toxin that is important. Local anesthetics that can be used through IV route as well. We normally inject them, but can be used as lignocaine. It has very good effects on this phantom pain. Calcitonin has not good evidence, but in some cases, the studies indicate that people use it and it is effective. This is the medicines. Then comes the important part, which is the interventional pain management, which is normally employed in more than 50% of the patients, especially if the pain is severe and it is not helping. So what we do is we can use this local injection. Mostly these are done for the stump pain. Local anesthetics are injected at the areas of neuromas along with the combination of steroid. Regional nerve blocks like femoral, if it is a lower limb pain, or sciatic. But we have seen that it is a little effective in this phantom pain. Then Botox, as I described earlier, it is can be used. This can be used along the neuromas or in the muscles as well. Sympathetic block, it is a very good block. Lumbar sympathectomy, we have seen we do chemical sympathectomy, and it is very effective, and the pain score, it really comes down. Then pulsed RFA can be employed if you see that the steroid, because steroids might have a short duration of action. So what we can do is we can the this use this pulsed RFA on the neuromas on the for the stump pain, and this ablation can also be done at the sympathetic level, and also at this neuronal levels we can ablate these neuromas with help of RFA. Then cryoneurolysis, peripheral nerve stimulation, and then finally, if there is no treatment is being effective and the patient is suffering from refractory pain, then we can use this spinal cord stimulator as well. This is shown to be very efficacious in the management of phantom pain. uh, Little about the evidence, because this phantom pain has not been much evaluated with the randomized controlled trials, especially these treatments of interventional pain management. So all the evidence is very weak, but the thing we do is we use this pulse radio frequency of the DRG can be done, pulse radio frequency of the stump neuroma, and lastly this spinal cord stimulation, because uh, they don't have any negative effect on the patients, and these things can be done to improve the pain. Finally, if nothing is effective, then we need to refer the patient to the surgeon, or in case sometimes neurosurgeon, if we see that there is some pathology like a protruding bone, exocytosis, there's some wound infection, because if the infection is not treated, the pain will persist. Whatever you do in case of infection or there is abscess, you can't inject into the neuromas. So it is very important that you the infection is treated. Sometimes the neuroma needs to be excised by the surgeon, needs to be revised, and the cut ends, they are just buried into the muscles. Then in some cases target muscle regeneration, sometimes maybe the plastic surgeons do that. And then also intracranial neurostimulation, deep brain stimulation, this neuromodulation, or this dress lesioning. This all treatments is mentioned in the literature, and they say that these all help in this decreasing this phantom limb pain, their intensity also, and also the duration of this phantom pain. Okay. So this was all about the management. I hope you all understood this, and finally this take home message. uh, Phantom pain is a common consequence, and we see in our setups also that once any limb or organ is removed, phantom pain syndromes occur. And commonly these are phantom sensations, but they develop later on into phantom pain, and in 10% of the patient they can be very severe, incapacitating. And the mechanism is just combined morphological, physiological, biological, these are all changes that occur, and it leads to this phantom pain. All these preventive therapy, they should be done. One cannot say that these are all effective, but they should be employed. Similarly, this treatment modalities, more research work needs to be done, and basically these spinal cord stimulators and everything, more research needs to be done on that case, so that but the evidence become strong. And at present there is no evidence-based approach to managing phantom pain that is available right now, but all these treatments, they have been shown to be effective. Okay. And lastly, the conclusion: this phantom pain, it remains a challenging endeavor. It is very difficult to treat pain. It becomes chronic, and the optimal treatment is that multimodal approach needs to be employed. And this multimodal approach, it includes preemptive analgesia, psychotherapy, education and rehabilitation of the patients, use of multiple drugs at the same time, and whenever procedural intervention is needed, it should be done as soon as possible. It should not be delayed, because it helps a lot. Thank you very much for your listening, and if there's any questions or comments, please.
Thank you very much, sir, for a detailed overview of this complex topic. Now the session is open for questions and comments.
Hello.
Sir.
Hello.
Yes, sir. We can hear you, sir.
There are 12 participants, and now I may ask, how many of you have seen the patients with phantom pain? कोई जवाब दे दे? सबने
Yeah,
देखा
Assalamu
है
alaikum,
कि-
sir. Sir,
हाँ,
Assalamu alaikum. Tahir here.
Yes, welcome, welcome.
कैसे हैं सर आप?
मैं गया था, कितने लोग, 12 लोग अटेंड किए हैं, तो 17 लोगों ने अटेंड किया है। कितने लोगों ने इसको देखा है फैंटम को एक्चुअली?
जी सर, मैंने देखे हुए हैं फिल्म में।
बाकी लोग आपने तो देखे ही होंगे।
जी जी सर।
बाकी जो है
सर,
जो नहीं देखा तो
सर मैंने भी एक दो देखे हैं पेशेंट्स।
ज्यादा ये उसमें ये होता है जो ट्रॉमेटिक सडन हो जाए, क्योंकि
जी।
जो कुछ कुछ पेशेंट्स को कहते हैं कि जिनको ऑलरेडी हेपेटिक फुट है या इस्केमिक लिम्ब है, उसको अगर आप प्री ऑपरेटिवली पेन फ्री कर दें विद एज केटामिन और एपिड्यूरल्स, तो उसमें चांसेस कुछ कम हो जाते हैं फैंटम पेन के। अगेन, लेकिन जैसा मौजूम ने कहा कि नथिंग इज डेफिनेट, and response varies from patient to patient. The complaints varies from patient to patient. और अलमास कुछ पूछना चाहती हैं?
जी सर, मेरा भी यही क्वेश्चन था कि इसमें एक तो आपने मैनेजमेंट डॉक्टर मौजम आपने बताई, थैंक यू वेरी मच, लेकिन इसमें कोई प्रिवेंशन की क्या स्ट्रेटेजी होनी चाहिए? कि लिटरेचर शोज कि आप अगर रीजनल एनेस्थीसिया, जैसे सर ने बात की एपिड्यूरल, आप एपिड्यूरल कैथेटर अगर डाल दें एंड यू कीप द पेशेंट पेन फ्री फॉर 2 to 3 days, इट हेल्प्स अ लॉट फॉर टू प्रिवेंट दिस फैंटम लिम्ब. सेम इज रीजनल नर्व ब्लॉक्स कि एक तो सिंगल शॉट नर्व ब्लॉक्स हैं, दे मे हेल्प फॉर 24 hours, बट अगर आप उसमें कोई कैथेटर डाल दें 2-3 days, इफ यू कीप द पेशेंट पेन फ्री, तो दैट हेल्प्स अ लॉट. आई मीन वी हैव सीन कि पेशेंट की जो फैंटम लिम्ब पेन है, या तो वो उसकी इंटेंसिटी कम होगी या वो नहीं होगी. आई मीन दिस इज वन ऑफ द प्रिवेंटिव मेजर्स.
सर ऐसे ही है सर, बिल्कुल
So,
यूज ऑफ एपिड्यूरल जो है
sir,
बहुत
is
इफेक्टिव है
this
सर.
for is this only for traumatic patients or for the patients who are going amputation surgeries otherwise?
नहीं, अगेन आपकी आवाज नहीं आई.
सर मैं ये पूछ रही थी कि ये जो आप बता रहे हैं कि preventive measures are if we go for epidural injections and blocks before the surgeries and if we put the catheters. So is this for a patient who is coming to you for amputation after a trauma or for any patient who is coming to us for amputations? What is your experience?
नहीं, वो तो देखिए आप कर सकते हैं ना, जिसकी प्लान्ड एक एम्पुटेशन है. बहुत सारे वैस्कुलर पेशेंट्स हैं, ये सॉरी कैंसर पेशेंट्स हैं, तो जिनका अपने प्लान्ड एम्पुटेशन करनी है उसमें तो आप कर सकते हैं एपिड्यूरल नर्व ब्लॉक्स. एक ट्रोमेटिक एम्पुटेशन अगर आती है तो दैट आई मीन दैट इज ऑलरेडी डन. उसमें डेफिनेटली पोस्ट ऑफ पेन आप मैनेज कर सकते हैं ड्यूरिंग सर्जरी, और पोस्ट पोस्ट प्रोसीजर आप यही प्रोसीजर में फिर उतना चांस जो है वो कम हो जाता है.
Thank you very much, sir. Do we have any other comment or question?
I think if I can just add a few things. Phantom limb pain के लिए जो है, what I found really helpful is early prosthesis, use of early prosthesis, and जैसे डॉक्टर ताहिर अकबर और डॉक्टर केबी ने कहा कि perioperative pain management, not only post but even before that, breaking the cycle, making sure that the patient is pain free pre-operatively as well while awaiting. क्योंकि हम लोग कैंसर सर्जरीज जब करवाते हैं तो they have tumor and some of them have very severe ongoing pain. And in some of these patients, we do see young patients, they would have phantom limb pain afterwards as well. Fortunately, well, mastectomy की हम लोगों ने नहीं देखी, लेकिन limbs की जो है वो बहुत ज़्यादा जो है sarcomas की वगैरह का जो जब ऑपरेट कराते हैं तो उसके अंदर है. Physiotherapy has extremely good role in this one. There was this graded motor imagery which was mentioned. Mirror therapy to karte hain, lekin graded motor imagery was something which was really excellent. It could not only predict people who are likely to be more prone to developing phantom limb pain afterwards, but also in terms of treating phantom limb pain. So graded motor imagery is more like considering the right-left orientation of the brain, how quickly it can pick that up. So people who believe in having a central mechanism or brain mapping को change करने के लिए phantom limb का, the people who believe that the phantom limb pain is more of a central phenomena rather than peripheral, they kind of like more rely on graded motor imagery for that reason. I mean, these are the few things is like that I thought was extremely important. और हमारी physiotherapy जो है overall, they should really be looking into these factors. मरीजों को जो है वो घरों पे हम लोग बता तो देते हैं कि like इस तरह से you can buy a good quality mirror and do the therapy yourself. Like for graded motor imagery, we would have to have these patients in a rehab setting, or in patients की जो है वो making sure that they have enough physiotherapy, enough of these imagery, and early prosthesis. These are the most essential elements in my view. Thank you.
Thank you so much, ma'am, for your input. Now we have a question from one of our participants. What is the role of gabapentin and pregabalin in preventing phantom limb pain? Dr. Moazzam, if you can comment on it, or anybody from the participants can comment on it, please.
Yes, gabapentin and pregabalin is effective. Normally, we see that it is not started pre-operatively by the surgeons, and when the patients come for us for surgery, so we can advise it for post-operative pain. The studies, I've read some studies. This pregabalin started 3 to 5 days before or weeks before about because it takes few weeks to become effective. So it prevents all type of post-operative pain, and it might also help for this phantom pain. But we have seen that this is not started preoperatively. If it is done, we could see that there is a decrease in incidence of phantom pain.
There is no harm in starting gabapentin pre-operatively. There is no harm.
Yes, sir.
और की बात बड़े खामोश हैं सारे लोग पार्टिसिपेंट सारे.
I think हमारे सेटअप के अंदर जो है वो सर्जन्स obviously वो सर्जन्स ही करते हैं, लेकिन ये कि they're more inclined towards carbamazepine for some reason, and I think that has to do with their age because they, probably in their time carbamazepine was the drug and pregabalin kind of
Yeah.
took off later on. So as long as there is, I'm not very particular which one, but as long as there is some kind of an anti-neuropathic drug given, and it should be titrated up as well according to response and the side effects. So a balance of both, but it needs to be titrated up as well. I think the gabapentins are now used in for management of acute pain, or was tried as well. And as far as I can remember, even for mastectomies, the prospect group had recommended giving gabapentinoids preoperatively. The dose seemed very large for acute pain preoperatively, but that's what they recommended.
But the experience and literature shows that the threshold of pain varies from patient to patient. Response to drugs varies from patient to patient. So we can't give a definite statement. तो अपना पेशेंट की किस्मत है कितना दर्द उसको होता है, डॉक्टर की किस्मत है कितना दर्द उसके पेशेंट को होता है. Anyway, thank you very much, Dr. Moazzam.
Thank you, sir.
Thank you.
Thank you very much, everyone, for joining in, and thank you very much, Dr. Moazzam, for your time. Inshallah, we'll be having you in our future sessions as well. Since we don't have any comment and questions, so the session is closed for today. Thank you so much, everyone.
Thank you.